observations we see, and we sometimes also see it in the media, is perhaps the perception of how palliative care patients are being treated. Palliative care services in our country and in other countries have been affected significantly, and there is sometimes a great deal of tension between the nature of treatment that needs to be provided for palliative care patients versus that of other patients and the general public at large. So I think it's an area that is of great concern to us. And since we keep getting into waves and waves of pandemic, and we're not quite sure whether there'll be a next one or next one, I think this is an area that I think is worth looking at, certainly from the ethical point of view. And what we have here are two of our really close colleagues. They usually come over here for cerebral and gastronomy stimulation. So we have our good friend, Professor Gauri Agarwal. She's head of palliative care department at Concord for the last 26 years, and she's currently the Deputy Clinical Director, Cancer Services and Palliative Care, Sydney. She's also the director of the chair of the executive of the Sydney Institute of Palliative Medicine. She's been a close colleague of ours, working not just with us in Malaysia, but also in many other areas in the Asia Pacific. And with her, we have Dr. Sumitra Menon. She is co-director of the Clinical Ethics Network and Research Ethics Support, the Center's support of the Center of Biomedical Ethics and the National University of Singapore. She is director of the Continuing Education, director of Organizational Development. She's director of lots of things. And very, very active in areas of teaching, undergraduate, postgraduate, as well as research, especially in the area of advanced care planning. Both Sumi and Gary are members of the Hospice Malaysia Ethics Committee, which keeps them wonderfully stimulated from time to time. So I'm really happy to have them here virtually, although it would be nice to have them here physically. So I guess we can get started with this really wonderful discussion, which is going to be based on a case study. So over to you, Gary. You could start by unmuting yourself, Gary.
Thank you very much, Ednan. That's a faux pas right at the start, isn't it? Okay, can everyone see that?
Yes.
Great. So thank you all very much, and thank you, Ednan. Sumi and I are very excited with this workshop, and we want to try and make it as interactive as possible. And so, as has already been said, please do write in questions and comments as we go, and definitely raise your hand if you'd like to discuss things with us or ask the question in person. So what we thought would be very helpful, it's been a very difficult 2 years of COVID, and some of us might even say we've had enough of COVID. But looking back, I think there are some real ethical concerns that have been highlighted through seeing patients and seeing our community go through the real wave of COVID. And so by using this case, we want to really have a discussion with you as to what some of those ethical issues and concerns that might have come up. Unfortunately, I can't see any of you, so you're just going to have to shout out if you want me to stop at any point. So this is a particular case that I was involved with in September of this year. And so her name is Mrs. CC, and she's a 73-year-old woman who lives with her son at home. And her son was actually in home isolation because he had symptomatic COVID-19 infection. So there's the mum and the son at home, and son's infected. And in August of 21, she comes into our emergency department with worsening breathlessness cough and not feeling very well, and she's been diagnosed with COVID-19. Her background history is she's got atrial fibrillation on anticoagulant therapy, hypertension. She's an active smoker, quite significant smoking history, and you can see that she's on some cardiac medications as well as cholesterol lowering. As I said, she lives with her son, separated from a husband, and has a daughter who lives fairly close by. And functionally, she's being very independent in terms of her activity of daily living and mobility, and she's not needed any community services or home help. So let's have a look at her COVID history. On the 23rd of August, she was diagnosed as positive with COVID. She was asymptomatic at that point. But it's unclear, it is unclear when she actually developed symptoms. And it's thought that 10 to 15 days prior to that first positive swab, she had symptoms. Importantly, her vaccination status is unknown. And her son, who is at home, as I said to you, is isolating because he is also COVID positive and became unwell 4 days before her. You can see that her oxygenation on room air is 92%, not too bad really, and with some oxygen it increases. Her respiratory rate, all of us would say, is quite high. Blood pressure not too bad, and heart rate a little elevated as well. And if we look at a chest x-ray, you can see the typical diffuse patchy infiltration around the right upper lobe and right lower lobe, consistent with sort of an overarching pneumonia on top of her COVID positivity, and she has mild oxygen requirement. So in our hospital, there are COVID wards where patients who are COVID positive go to, and she was admitted to that ward and treated with what would be standard treatment here: intravenous steroids, IV remdesivir, and for the bacterial superimposed infection, she's on some antibiotics. Over the next 5 days, she has minimal ongoing oxygen requirements, but that's actually improving, and it's really minimal. Improving inflammatory markers, and she's very independent with self-care and mobility on the ward. So at that point, as I can't see any of you, Ednan, would you like to ask any questions or ask the audience for any questions? Are there anything in particular for clarifications, or already are there any ethical issues?
Okay, there's a chat question from Dr. Lin. Can you see, Prof. Gauri? In Australia, do all COVID-19 symptomatic patients require hospitalization?
Okay. So in the early stages of the COVID pandemic, most patients were actually brought into hospital more from a standpoint because we had low numbers and to make sure that they were quarantined and isolated from family members. As the Delta wave occurred in later part of 21, there was a less of a requirement, and we started to care for COVID patients more and more in the community. And so the distinction became that those patients who were asymptomatic were managed obviously in the community right from day one with strict isolation, but those who were mildly symptomatic now were managed in the community by different virtual platforms and COVID community teams, and only those requiring high level of care were brought into hospital.
Gary, I do have a question. With regards to the patient, how aware was she of the nature of her illness and the seriousness of it? And what was her goal of care at this early stage?
So I think she was much more concerned about not being allowed to be at home not being allowed to have her son and daughter visit her. And so, you know, I think there was a slight language barrier as well. And she was very dependent on her family. So I don't think she understood the importance of what COVID meant, although the media was now really showing descriptions of what could happen and talking about death rates, etc. But she personally was not too worried for herself. It was more the lack of communication with the family and isolation in hospital.
The other follow-up question was that at this point of time in September, what was the sort of prevalence of COVID cases in your setting? I mean, we sometimes were having sort of cases overwhelming into car parks and things like that. But I'm just wondering, was in where you are, are these just a few cases, or you also had several dozen cases to deal with?
Okay. So September was when we were in the middle and almost at the peak of the Delta wave. And so in New South Wales, which is the state in which Sydney sits, in New South Wales, we were having up to 900 positive patients in the state, and taking it up to about just over 1,000 in the whole of Australia. So if we come back to Sydney, slightly smaller, it was mainly around the metropolitan Sydney. So in my hospital itself, which is about a 650 bedded hospital, we had 5 COVID wards, and each ward having anywhere from 15 to 20 COVID patients. So they were spotted all over New South Wales. And so palliative care were probably involved with, at any one time, maybe 2 or 3 COVID patients more approaching the end of life.
Great, thanks. Any other questions from anyone? Please just type them in. Otherwise, you can continue, Gary.
Dr. Sylvia raised her hand. Oh.
Yeah, I think my question is really similar to Edna's, which is trying to understand a little bit more about her background and how you mentioned a language issue and how independent she was. And I'm trying to understand what sounds like quite a prolonged presentation, whether there was anything else going on and what really led to her hospital admission, what precipitated that.
Yeah, so this was a fairly independent woman at home who didn't need any assistance for her activity of daily living or functional side. She cooked, she cleaned, she cared for her son, very closely involved with her daughter. And really leading up to it, she was medically quite stable. What led to her admission was the fact that she was becoming more breathless. And so the concern that her son was COVID positive, she had also turned up being COVID positive, hence she came into hospital because of breathlessness. So moving on to part 2, things do take a turn, Sylvia. So something happens. On the 31st of August, she in fact has the medical emergency team called suddenly to the COVID ward because she looks like she's had a stroke. She's got new right-sided weakness and in fact a very urgent CT scan, which poses a bit of difficulty getting a COVID positive patient into general hospital for a CT scan. She now has a large left middle cerebral artery territory. So you can imagine one of the main arteries to the brain, large infarct, mild mass effect without midline shift, and in particular, there's no hemorrhagic transformation. So now we have someone who's COVID positive in hospital, and she's now had a huge stroke. at this point, are there any ethical issues? And those ethical issues, is there anything that we need to consider to manage her? Sumi, do you want to make any comments at this point?
Yeah, hi everyone. Well, I was hoping that we might get some input from the participants, right, based on the case that's been presented so far, and Mrs. CC's sort of journey to this point from having COVID and becoming breathless and having to be admitted for to manage those symptoms and provided with some relief, and then now she has what looks like quite a serious stroke. And I suppose some of the questions that may arise, the most obvious one, I suppose, is what we should do in relation to her management, right? Do we treat her? To what extent is her contracting COVID a factor in, if at all, in managing her stroke? So do we change our approach towards her care because she has COVID-19? So I don't know what the participants think, but maybe they might want to type something into the chat and tell us perhaps what you think, and perhaps even what has been going on in wherever you are around the world. And we understand there are quite a few of you from all over the place. Apart from Malaysia, I think there are some people from Singapore and Philippines, and even somebody from Panama, apparently. So please don't be shy.
And be happy to raise your hand, and we'll let you ask the question in person too if you don't want to type it.
It might take some people a little bit of time to type, I suppose. So maybe then it's an opportunity for me to ask Gary a little bit of a follow-up question on Mrs. CC. So you mentioned earlier on that at this time there was a bit of a Delta wave going on in New South Wales, and cases have been rising. And at that time, Australia had really been pursuing a kind of zero COVID strategy. I'm not sure whether that's exactly the case anymore, but it was back then. So in terms of the pressures on the healthcare institutions at that point, what was it like? Was there a bed crunch at this point? Did some facilities have to be converted to accommodate COVID patients? Maybe you can give us a little bit more of the kind of context.
Yeah. So the Delta virus time, things exploded for us. And it's interesting because around the world, when you use the word exponential in places such as even United States, but closer to home, India, Malaysia, Singapore, or not so much Singapore, I think the exponential was huge numbers. In Australia, it's all relative. So for us, it was still a major peak. It put huge demands on healthcare, and it was an interesting dilemma about utilization of resources and the justice around that. So some of our audience might pick up on some of these principles. But one of the issues was that there were about 20, maybe 25 major teaching hospitals in metropolitan Sydney, but 5 of ours were in areas where there were large spikes. And so now we were finding that certain hospitals were caring for the bulk. As I said, we had 5 COVID wards. So then it put a huge stress and strain on our medical force, on our nursing force, on the hospital, on the budgets, etc. So there became a disparity, and there was a lot of anger, concern, and difficulty for healthcare professionals to manage in the context, because we were then being pulled away from our normal business. So ward-based care instead of teams, lack of support. So COVID changed the way we cared for in some hospitals, not so much in other hospitals. And that might pose an ethical dilemma in itself too.
Yes, That sounds very interesting. I think Ednan was about to say something, but I've seen at least a couple of hands up. So Ednan, you might want to.
No, there's a question in the chat box. If basic medical care is an entitlement, why is a COVID patient deprived from such treatment? If the hospital are not equipped to care for such patients with such conditions, shouldn't a transfer be facilitated?
So thank you for that question. But in fact, all of our hospitals very rapidly in 2020 were able to absolutely manage COVID. So our hospital and all hospitals, in fact, had ICUs and high dependency units, which looked at evidence base and were able to manage. So she was actually in the right space. In a COVID ward that had respiratory physicians, intensivists, as well as other clinicians caring for her. So she was actually there. She didn't require to be transferred out. If she was in a smaller hospital without that expertise, she would have definitely been transferred out. But ours is one of the major teaching hospitals. And so we had the capacity, capability, and infrastructure to do it, but at the same time, it put a lot of stress and strain on the hospital system.
Got two questions here. One from Dr. Saiful, one of our young specialists. Saiful, can you unmute yourself or even show yourself and pose your question?
Hi, Gauri. So I'm actually here with the whole team from Selayang. Actually, I'm broadcasting you here as well. But what I would like to ask a little bit is because during the whole COVID era, our hospital changed into a full COVID hospital, and just looking at this case, it kind of then made me wonder, because I think some of our patients were having some of those issues where they came in because of COVID, then they've got some of the medical problem, and then you start noticing that they're not managed by the best team that would have managed these kind of patients if we were not in COVID era. So, for example, if this was not, if there was no COVID for this patient, she would have been best managed in a stroke unit, and those would be the right resources that would be caring for this patient. But would it then be fair to say that she's in a COVID ward being taken care of rightly by the COVID team and the respiratory physician, but would that be the best management for the stroke that she's having now? And should she then be transferred out? And I think we got those few patients like that as well here when we were treating for those COVID, and they've got some of the complication that might be related to other field. And then we were like, how do we allocate the resources to the right setting? So I'm not sure if that's what's happening here, but it kind of, made me wonder about those things that were happening here too. So I just wanted to make that comment. Yeah.
Thank you, Saiful. Extremely important question that you're asking. And I'm going to give the medical side, and I'd love to hear Sumi's side of things from an ethical standpoint as well. So Saiful, you're absolutely correct. And one of the biggest ethical dilemmas and professional moral dilemma was the appropriateness of care for every patient that, even though, well, they had COVID, but as you said, had different medical problems that were still ongoing. And in the media, we had a lot of attention in particular for cancer patients, that they wouldn't necessarily get adequate oncology or palliative care. In fact, palliative care, the lack of palliative care in patients who were dying was considered. So very rapidly in 2020, this is why we didn't develop COVID hospitals. We had COVID wards, but every specialty had to have their senior most consultant or registrar made available in full PPE to consult with patients. So it became a shared care. So even though they might have been under the intensivist, if they were in ICU or high dependency, or just the COVID ward under the respiratory physician, they also had a geriatrician, a neurologist, or a gastroenterologist, depending on what other reason they came in with. So in fact, that whole concept of requiring good in parallel care with that specialty, I think was a real dilemma. and many countries worked it differently. And for us, I think we made the right decision that we had ongoing consultation, but was it adequate? Was it as good? Is the question that I now sort of theoretically pose to Sumi. Thanks, Sumi.
Thanks, Gary. And yes, excellent question. Yeah, I mean, it raises, the question of how, to some extent, organizational ethics, right, and planning. And with hindsight, everything might seem a little bit more obvious. Oh, we could have done that, or we should have done this. But at the time, sometimes some very hard decisions had to be made, and some compromises had to be made, and that depended on a lot of factors, including how the resources that were available, how hard COVID had hit the country, the existing structure, right, will also make a big difference in what your response is going to be from country to country, because it depends on how your healthcare system, your acute care, your home care, if you have any, how all of that is structured. So I think I would agree with Gary to the extent that ideally you want to minimize these sorts of transfers for patients to the extent that's possible for very many reasons. And most patients, well, not most patients, some patients with COVID will inevitably have something else, other comorbidities, other conditions that they have to manage, right? It will only be the really young and healthy or lucky who will be, have COVID in hospital and not have anything else, no other comorbidities. So it kind of makes to maybe convert some wards. I don't know what the situation is in some other countries, but certainly quite a few hospitals in Singapore did convert some of their wards into COVID wards within the hospital to accommodate more COVID patients, and they tried to spread that out across the island. So then the core medical, the core medical services could still be provided within that hospital without necessarily having to transfer the person out, unless perhaps it was a very, very specialist thing, but I doubt if that would have happened. I don't know if that answered your question, Saiful.
There's another question from Dr. Shankar. Dr. Shankar, would you want to unmute and ask your question, please?
Can you hear me now?
Yes, we can.
Hello. Yeah. Okay. Now, basically, just based on the question, are there any ethical issues? The question of whether to treat or not would not arise. Basically, from the presentation, you can see that the patient's condition is not deteriorating or is such a bad condition that you need to think about whether it's futile to treat or not. Based on the information given, the inflammatory markers were getting better, the SpO2 oxygen levels were improving. There is no issue of futility of treatment. So that should not arise at all, whether to treat or not. Unless the patient was in such a bad condition, then you may need to think whether it is futile to treat the stroke. Now, the second part of what Dr. Saiful asked is, you having, whether the right person is treating or not. That depends on the circumstances. When you talk about ethics and moral, it is never fixed. It also depends on the circumstances. If you have the required specialists and expertise, then the moral issue or ethical issue arises. But if in a situation you do not have the speciality, then if you look into things, a doctor, the only consideration is if you are not trained, then you should not treat. I mean, most of the doctors, even the intensivist, the physician, everyone is a trained doctor and usually a specialist, whether they are a physician or not. A physician just doesn't look into respiratory conditions only. They are also trained in, cardiovascular and many other things. So there is no such thing as a fixed and fast rule when it comes to ethics. it also depends on the circumstances. It depends on the resources. I mean, that's my take on those questions. Thank you.
Thank you for that. And I think you have a very reasonable, explanation of resourcing. And sometimes within resources, we have to strive for the best. So ethics still remain a paramount of paramount importance within the context of that healthcare system. And so resources sometimes dictate that. I guess if you step outside that to say what's the best for this patient, then the arguments of who would be the best care for the patient and the skill mix, which is what you're talking about, a general medical clinician physician is able to do a lot more than just cardiology or respiratory, and I completely agree with you. But in a circumstance where you have the resources for interdisciplinary communication, then it's actually in the best interest of the patient. But what I might do is go on to the case, because I think we've got a bit more of the jigsaw that I'd like to show you. And so what happens is, so as in this model, in fact, Saiful, your question, the neurologist did come and review the patient in full PPE with his team in the COVID ward to really give the main treating team an understanding of what was happening. They determined that it was a catastrophic large infarct, not amenable to reperfusion. So you're absolutely right that at that point, the decision to treat wasn't just based on COVID, it was based on the fact that if she had minimal infarction, she should be considered for reperfusion. So all those right steps were taken into account. The risk factors being COVID positive with a higher thrombotic evidence, atrial fibrillation as well, she was a smoker, and in fact, she had newly developed polycythemia. So overall, the decision was that there was a very guarded short-term prognosis as the patient is at high risk of malignant cerebral edema with worsening mass effects, so rapid is what I meant. And if she survives, she will have significant disabilities in the long term and probably will be aphasic, dense hemiplegia, and will need 24/7 care. So the neurology review on the 1st of September was minimal functional recovery, treating team to discuss with family, and someone, I think Zini had said, talk to the son. Absolutely. Where is the family in all of this regarding treatment preferences for her stroke? And so in that framework, a palliative approach versus active treatment was debated. And I guess, we're talking about futility or the appropriateness and inappropriateness of certain treatments. A nasogastric tube or a rice tube, I think you call it in Malaysia, was inserted, ongoing parenteral fluids at that stage. However, function was likely to be seen to be poor. Patient was most likely will not be able to return home, and most likely will need long-term nursing home care if she survived. I think we've discussed it at this point, and I think we'll keep going because of all your great questions. I guess the one question that I wanted to know, because we've already sort of tackled a little bit about whether the stroke impacts how we manage and whether COVID impacts the management of the care. But here you've got someone who is unresponsive, not able to give us any verbal cues. So can I get people to talk about the decision-making process from an ethical standpoint?
Gary, there's a question in the chat box. Now that the patient has developed stroke, possibly as a result of COVID's complication, I reckon this may complicate ethical decision-making process in management of COVID should her condition worsen. Would this patient be considered an ICU admission or mechanical ventilation if her COVID condition worsens because she's now developed a stroke?
So that's a very interesting aspect. And it really comes down to the underlying perspective that in a human being, we can't isolate an organ and isolate a disease process. And we need to look at the human being in front of us. And when you've got multiple significant deterioration, the compounding effect then does lead to a discussion around futility or appropriateness of treatment. In this situation, it's not her COVID that she's deteriorating from, it's her stroke. And so the neurologists feel that we can't reperfuse, and reperfusion would mean ICU reperfusion post-reperfusion improvement or response. They actually feel that it's a very large stroke and she's probably not going to do very, very well. So in fact, it's the stroke that's now changing the appropriateness of the intensity of care. And I would think at that point, we're actually saying she would not be for ICU admission based on the stroke and post-stroke, but we're still treating her intensively enough in a ward situation with feeding, fluids, and bringing her blood pressure down. So not mechanical ventilation, not ICU. Unless there's another question, Sumi, do you want to say anything at this point?
There is another question. It's about whether or not there is, did this patient make an ACP or any other type of directive?
So this patient had not had an ACP. And I think that was one thing that the pandemic very quickly made all of us very aware of. One was the requirement to start having conversations with all patients with chronic disease and certainly with advanced stages of their disease. And two was for palliative care services, what was symptom control guidelines for the care of patients with severe symptoms that didn't require ICU and ventilation for COVID, but required ward management. So ACP was something that we actually had to do, and advanced care directives were something we were pushing. Sumi, did you have a comment on that aspect of it?
Well, certainly in Singapore, I think that ACP had a bit of a boost. There seemed to be more conversations going on, anticipatory conversations in case things didn't go to plan, especially, and trying to minimize any sort of confusion or other problems, right, in terms of expectations of families and their loved ones in the event that their condition changed and required a change of management. So that certainly did have a boost, and I think that overall that's a good thing, generally speaking, about encouraging those sorts of conversations. So if that's one thing that's come out of COVID, then that's a positive one. In relation to this particular patient, I think Mrs. CC needs to be the management of her care needs to be perceived in a more global way. So you can't separate like the COVID from the stroke. Mrs. CC happens to have COVID and suffered a stroke. So, certainly in terms of her clinical management, it needs to be looked at from a global perspective and the goals of care considered, right, in terms of what would be the clinically appropriate care for her, but also what would be ethically appropriate that would maximize her in terms of the benefits and minimize the burdens to her. So that might require more of a conversation in relation to what her prognosis is, what and to the extent that's possible, conversations with the family in relation to what her preferences may have been. Hopefully there, I don't know what, maybe it doesn't sound like there were any sort of main known preferences in this case.
Not ahead of time, so no discussion, because essentially, she was a fairly healthy woman with some comorbidities of cardiac, but nothing that may have spurred a advanced care planning conversation. Did anyone want to comment from a Malaysian perspective, Edna, Sylvia, or anyone else?
I think someone has their hand up. Is that Sylvia? You got your hand up.
Dr. Shankar has his hand up. Dr. Shankar?
Yes, something very interesting. I noticed that they put in an NG tube, and just like the previous comment, you know, she was a very independent woman. She was quite hesitant to come into hospital because she wanted to look after her son, and so when you talk and when you know the prognosis is bad, I was just wondering whether that is what the patient would have wanted. She was very independent and all such things. So to put an NG tube without having thought about what is the best interest of the patient is probably something that we should also think about.
And thank you for that. I think it's an extremely valid comment that you make. And without knowing her wishes, and maybe that's the bit of jigsaw puzzle I haven't given you, or maybe we didn't have it. That where's the conversation with the families, and what would what in her best interest for those that are persons responsible or next of kin, do we have an idea of what she would have chosen in this situation? And so you can see, Dr. Shankar, that she's just following almost a stroke pathway, because what do you do in a stroke? You put in a rice tube and you feed and you do those sort of things. So I think it's a very valid comment. Edmund?
No, I'm just looking at the comments. That there's a there's similar.
Family. Should we move on to the family then? Because I think I've got it in the next slide. I'm hoping. Bear with me. Okay. So here we go. And what's the most distressing thing is for the family, they're at home. You've got the son at home who's COVID positive. You've got a daughter who she's very close to. And so there are conversations not occurring in person around the bedside, but by phone. The daughter, in fact, opted for conservative management. As she says, Mum would not like to go to a nursing home, knowing the prognosis and knowing that her recovery at best would be a phasic, right-sided neglect, etc., and paresis as well, paraplegia, or hemiplegia rather. Agreed that patient would not like CPR or intubation and for palliative symptom approach. So the IV fluids were ceased, the nasogastric tube was removed, and routine observations were minimised, and a palliative end-of-life care plan was put in place. So that was the first to the third. There were daily telephone family updates, both with daughter and son. Often we would use a tablet if the patient was awake and speaking, but not in this situation. The patient was comfortable. There was no cough. Occasionally was noted to be chain-stoking. Treating consultants discussed with COVID respiratory consultants, so the neurologist and the respiratory, about the COVID-19 symptoms. They were thought not to be infectious, and once she became day 17, it would be good to get her out of a COVID ward and into palliative care. So palliative care had been seeing this patient in full PPE alongside the respiratory physicians, the intensivists initially guiding that acute care, the neurologist, etc. And so we were consulted, and the family were in fact pushing to get her over to the palliative care ward because we had a better visitation policy. And during that time, we'd already had a conversation, because what were we going to put on the death certificate? It was considered to be a large left middle cerebral artery territory stroke with an antecedent cause of COVID-19 pneumonia. So both causing her death, and she was transferred to our palliative care unit on the 3rd in the afternoon. While she was there over the next 4 or 5 days, she was in a terminal phase on arrival and in the palliative care unit, and this was something that we had to fight on. So can I tell you that palliative care services came together and we were guided by Ministry of Health, and we had a community of practice for COVID, for neurology, for respiratory, for intensive care, for A&E, for oncology, for haematology, and palliative care had a community of practice. Every district had a palliative care representative that sat at a COVID meeting to deliberate what were the things that were important. How do we approach symptom control? How do we approach end-of-life care, communication, and certainly one of it was to push for visitor policy. So in the whole hospital, there were no visitors in the COVID ward or outside the COVID ward, but I pushed very hard in my unit. So we allowed 2 visitors. So that was an important thing. Patient was comfortable. She required very minimal PRN medications, eventually needing a syringe driver, continuous subcutaneous of 10 milligrams over 24 hours. And we know actually from COVID evidence-based data that's come out from large studies, including Australian, that the opioid requirement from just pure COVID is minimal, much less than we originally anticipated. And family members present multiple questions surrounding patients' deterioration. So I now want to pose to you, is it fair to restrict the number of visitors to a hospital? What do you think is our responsibility for the patient who is dying? And what about patients and families' rights? So do we have any questions, comments on those questions that we're posing?
I think that's the question. What would the hospital do if the family requests that the patient wish to die at home?
And we had many of these. And so in a way, I don't want to pursue it too much because it's part of that question that I was asking, but sometimes we're dictated by public health policies, aren't we? And so there's a tension between families and patients, public health policy, safety. So in this case, while she was positive, COVID positive, she wasn't going to be released out of the COVID ward. And then other members of the family coming in to see her at home, had a very large, extended family, not immediate children. Would they pose a threat to healthcare workers that would have to visit her at home? So without answering it too much, I'd like a conversation around that.
Well, we have Chang Tak Wai wanting to ask a question. Could you unmute yourself and pose your question?
Hi, I'm Dr. Chan Tak Wai. I'm actually a hospital ethics hospital in Singapore. And like Sumi, I'm a bioethicist in Singapore. I'm a pharmacist by first training and recently got exactly the same case that you have. So patient actually went to A&E with mild COVID-like symptom, haven't identified and haven't diagnosed. In the process of being diagnosed, got a stroke, very terminal stroke, and then had the same issue that is being discussed. So it was a challenge. That's why I personally thought this was a very timely discussion. And I went through the whole case and therefore had a lot of reflection as to how the hospital and healthcare system can do better for patients. So of course, subsequently, the good part of our case, my case is that the patient subsequently do not have COVID. And she preferred to die at home. She was discharged to go home. And she died peacefully in her family's care and love in 5 days at home. So here it is. Your questions are more than fair in that sense. That in Singapore, I think even for terminal patient, the number of people going into is very restricted in all hospitals. In fact, at one point in time, nobody can get into the hospital. And getting into the hospital is to die alone. Now, we all know a good death. I think in this panel, every one of us would think that dying in the love of your family, in a comfortable place, in a familiar place, with familiar people, and loved by everyone is a good farewell. But unfortunately, during this period, and you are right to say that there's restriction and healthcare restriction, but I guess at the end of the day, in the word of compassion and rights and care and ethics, the rights of the person and the patient must be respected. Of course, there must be due care and due place. And if the home is not suitable, then there should be a proper place where people can be allowed to die. And we are all advocates of a good death. So here it is. I don't have the answers. And in your case, I think it must be a very difficult case. And I'm sure it's very difficult for Mrs. Cici's family, who suddenly saw the mother being a strong woman, suddenly deteriorated to a situation where she became terminal and therefore accepting death and refusing treatment. So I empathize that case. And these cases are going to be much more. And therefore, and you're right, you know, and Sumi and I have been advocating ACP and talking about ACP since the beginning of time. But here it is. I think ACP is not a situation where only when you come to a hospital then you start to talk about. There should be a much better promotion for it. That's my view. Thanks a lot.
Good point, Sumi.
I mean, there's so much to dive into here, right? So maybe if we go back to the questions that you have on the screen, right? So is it fair to restrict the number of visitors to hospital, especially when we're talking about, or maybe it is different depending on the circumstances, right? So I think you mentioned public health policies. There may be very legitimate reasons to restrict the number of visitors to hospitals. And I would imagine that with, I'm not sure about other countries, but certainly, well, maybe other countries would also, as we kind of progress with the pandemic, fine-tune visitor policies a bit more. So they may even have vaccine differentiated policies for who's coming into hospital to mitigate risk. So it's fair in the sense that the goal is to minimize harm, right? Because of the potential for infection and to maximize benefits, but also to reduce any burdens there might be on healthcare professionals who then have to also, and other administrators who then also have to manage the inflow and outflow of visitors, which might disrupt to a certain degree how healthcare is practiced now that we're in the pandemic, right? Because it's not like before, the way the setup and the arrangements are quite different, along with the PPE requirements and so on. So it is fair, but it's unfair in the sense that in terms of how families are feeling and patients are feeling, in terms of managing their emotions, in terms of managing their bereavement, in terms of managing loneliness, not being able to have final in-person goodbyes with somebody and having to do it on telephone or video, that's all very unfair and terrible, and could have, some sort of lasting effects on the people concerned, and that is unfair. But sometimes it can't be helped, and so we have to hope that things get better. And I think they are kind of getting a little bit better. Might be a little bit patchy here and there. So that we can actually have policies that are a little bit more flexible.
Gary and Sumi, I would like to ask a question, because I mean this issue of visitors has been going on for some time, and I think that the two issues I want to bring up: the fact that in generally no visitor policy seems to be the norm everywhere. Now tell me about your persuasive powers that you could compel your hospital authorities to allow visitors in your palliative care and not in other settings where they may also be dying. And so you've got people dying in ICU, you've got people dying in other areas. So what's so special about palliative care that you can have visitors whereas you may not have the same visitors to a similar type of patient in another part of the hospital. So that's one question. With Sumi, the issue of the rationalization of justice in terms of you're protecting patients and that's in comparison to others who may get COVID. The no visitor policy has an adverse effect on the community so that patients who could get treatment even for non-COVID situations do not want to go anywhere near a hospital because you go in, you can't get visitors and you might not get out. So people who could get treatment for amenable medical treatment, I mean, even things like just a basic blood transfusion, doesn't want to go anywhere near a hospital. So does that come into the discussion of where this kind of policy leads to?
Thanks, Ednan. So I'll tackle the first one. Because I sit on the COVID executive committee for the hospital, I advocated for end-of-life care for all patients. But because mine is an inpatient unit that I can control, being a 20-bedded standalone facility within the hospital, we were able to firstly demonstrate how safe it was to manage visitation to a standalone facility and developed policies and guidelines as to how we would do that. The level of PPE, screening, etc. And vaccination didn't even come into it at that stage because we're talking about early 2020. And once we demonstrated that we could do that properly for the rest of the hospital, non-COVID ward. So COVID ward never was allowed. Even if you are dying in a COVID ward, you were never allowed. And that comes to that real tension between three things. I talked about public health, but I want to bring up something else, and then family and patients is staff. But in the rest of the hospital, we had a process by which you could escalate for an exemption as soon as we diagnosed dying. And it didn't have to be palliative care diagnosing dying. It could be the oncologist, the geriatrician, the neurologist in their wards. And once patients were in a single room, they were dying actively, we could escalate and allow visitors to come to that ward. And our hospital was commended, and we actually led that in the state, and then other units through that community of practice that I told you, all directors coming in. We learned from each other and the strategies to use. And before I hand over to Sumi for that second question, one thing I want to say is we talked about patients and families' rights. We talked about communities having a right, and that's what a public health order was to protect our community. Who was protecting our staff? And so all of us that worked within healthcare had huge stressors. My biggest issue was really not dealing with all of this. It was dealing with staff that were constantly being burnt out because they were afraid of contracting COVID themselves, especially in the early days and pre-vaccination. And so in that, I think there are not only rights of patients and families and community in terms of public health orders, I think there are staff rights as well. Over to you, Sumi.
Yeah, totally agree about that. It has to be a 360 kind of perspective. It's not just any particular group. We have to think about the community as a whole and the impact of COVID-19 on the community as a whole. So to address Edna's specific question, yes, visitor policies where people are restricted from seeing their loved ones, especially if they are very ill, whether it's in a palliative care ward or not in a palliative care ward, could be in nursing homes, because certainly in nursing homes, we also had restrictions in Singapore, and I'm sure that was the case in other countries as well. This may well put off people from seeking treatment. Obviously, that's not the goal, but you can see why some people would not want that. They want to stay, especially if they rationalize that the situation isn't so critical, why they would want to stay in the comfort of their home and be around loved ones and be in a familiar environment. So I think some of the steps that we can take are looking a little bit more at home models of care. There's certainly home hospice care, for example, that could be provided to patients. And of course, the question is, would it be suitable? It depends on where we are in the pandemic about the suitability of offering something like that. We're now reaching a stage in the pandemic where that's certainly much more viable, and that's something we're actually doing in Singapore now. It does take a lot of effort in terms of workflows and ensuring that the appropriate protections are taken to minimize, avoid infection, but it certainly is possible. So home models of care, where it's appropriate clinically and in terms of safety, is something we could look into. The other thing, of course, is the growth of telemedicine. Providing care to patients through, basically this kind of channel, Teams or Zoom or whatever it might be that people are using these days to communicate. Telemedicine certainly has blossomed. I mean, certainly in Singapore, lots of GP models are now done. There's a bunch of them available for people to choose from. And that has been a good thing, but it also could potentially be something that brings up lots of issues, actually, when you do telemedicine. There's issues of privacy and confidentiality. There's issues of patient safety. There's also obviously issues of justice, right? Because in order to be able to access that in the first place, you need to have decent Wi-Fi or fiber or whatever it is. You need to have some sort of device that's fairly reliable to connect to the internet. You need to be able to use these tools. So that is an issue that we also will have to address. But I think the bottom line is that there can be justifications for when visitor policies need to be put into place, but we just have to be mindful to recognize that it has a negative effect when patients can't have access to their loved ones, and to try and minimize those policies as much as possible, or facilitate access in some way to patients, especially those that are seriously ill, to their loved one.
There's a couple more questions. Gauri, you want to comment?
Sorry, no, ask your question.
No, I'd like to, Dr. Shankar has got a question, and after that, I'll get June to bring up her question. Dr. Shankar? You've been waiting a while.
Yeah, I just want to, no, not an issue. You were talking about patients' rights as well as visitors, relatives' rights. But we must also understand you only have rights as long as you don't infringe on other people's rights. If your rights infringe on other people's rights, then your rights are, questionable also. And the other thing is, these hospital visiting policies and all. For me, I would consider, we should not just think about our hospitals being safe and therefore I can keep my hospital and it's safe enough so that people can visit. But you also have to understand, you have absolutely no control about the visitor after he visits, and also your staff. They don't stay in the hospital. They go back home also. They are able to contract COVID from outside, and then they come back to work the next day. And the amount of resources that you're going to spend on doing daily RTKs or something to make sure that they are not, spreading the disease, it is going to cost you too much. That's my part of it. So I think it's very important that the visitation policy, I think it is made with due consideration. Yes, patients are important, relatives are important, but, we need to think the relatives go back, and they can also, the staff also go back and they can contract and bring it back to the hospital. That's my comment. And just one last question. I was just thinking, I noticed that the nasogastric tube was removed. My question is it ethical to remove? I believe that it should have, before putting it, due consideration discussion should be done, rather than after putting it in and then talking to the family and then pulling it out. Just that. Thank you very much.
Thank you for that. So the last bit is a good ethical dilemma to discuss. So withholding and withdrawing treatments that are inappropriate are considered ethically appropriate and would conform within ethical guidelines. Withholding treatment is so much easier than withdrawing treatment, and you're sort of alluding to that in a way. And the question you posed that at the start, should this patient have had a nasogastric tube? And I agreed with you, it might have been part of a stroke plan and we may have managed it differently. But at a point where the decision is that this patient is in a dying trajectory and was actually imminently dying, more in the terminal phase, artificial feeding, either with parenteral fluids or nasogastric tube, are not in the patient's best interest. And it comes to something that's been on the chat about us not always referring just to patients and families, but making appropriate medical decisions. And so offering and continuing futile treatment is not in the best interest of a patient. And so removing the nasogastric tube is actually the appropriate treatment in this patient's care. And so it conforms within the ethical principle of not causing harm. So I think that's an important one. Was there another question, Ednan, from June?
There's a question from June that I think might be best delivered verbally than read. So I'm just wanting to invite June to, can you ask your question directly? Would you want to? The way it's written, it says, do you see the value of having ACP discussion for COVID-19 patients in early categories? Having an acute illness, potentially reversible, and being emotionally overwhelmed, query mental.
Hi, Dr. Anin, can you hear me?
Yes, we can. Wonderful. Haven't heard your voice for a while. Go ahead.
Yeah, thank you so much for the very interesting discussion. I just wonder if it's possible for me to take the opportunity to share a very practical issues that we encounter in, I think, KKM or Malaysian public hospital settings, and perhaps pick on the expert brains. Because I think since the surge of COVID-19 in the country, there has been also a surge in the interest for ACP discussion. So everyone's saying, oh, let's do ACP, let's do ACP. But truly, I'm not sure whether they are really talking about advanced care planning, which involves exploring patients' preferences, or they are actually talking about setting the care, setting the ceiling of care early using guidelines or the local policies. So I'm not really sure, when someone admitted for COVID-19, whether it's Cat 1 or Cat 2 or Cat 4, do they still have the capacity to actually have a discussion, and and from the staff perspective, is it worth risking the staff safety to sit in at the bedside for 1 hour asking patients what matters to the patient? Yeah, so I don't really know, although ACP almost sounds like a romanticized way of sorting out the ceiling of care thing for the policymaker or for the administrative level people. But are we really talking about ACP, or actually just doctors trying to set the ceiling of care early for inpatient settings? So that's one question. And if you don't mind, a second follow-up question is, we also realize, personally, I just wonder how ethical is it to actually discuss about treatment options that are actually not available to patients. For example, when we were at a very critical stage where ventilators and beds are not available, or some hospital not even oxygen pods, as you probably have read in the papers, then is it actually worthwhile telling the family when we update the patient's condition that, hey, look, your father might deteriorate and he might need a ventilator, but we don't think, we have that? Or is it more ethical to just not discuss the options and just say we'll try our best, but we can reassure you that we will try our best at least to keep him comfortable if we can't save his life? Thank you.
Thank you, June. They're very complex situations and questions that you're commenting on, and I think you're throwing out a big challenge, and I don't think necessarily there are black and white answers. So that's the first thing. Very importantly, and I think Chan Tuk Wai has also said that ACPs occur too late. So you're right. That when we talk about advanced care planning, we in fact want to start those conversations very early, and it's about patients' preference and trying to work out what they may choose to do in certain circumstances. When a patient has COVID, what we're talking about is still a patient's requirements of having honest conversations. So if it takes an hour of sitting by the bedside, and often you don't need an hour to sit by the bedside, and I think that's the other thing that's part of maybe communication skills or the fact that you don't do everything in one time period. But the conversations then become about this particular illness and what would they choose if they were going to deteriorate. The most important thing is, which I thought you might be alluding to, is as a professional, we cannot hand over the burden of medical decision making purely on lay people. So it needs to be a shared decision making and conversation, but we can't actually say to people, what do you want to do in this situation? And it comes to your last point about, should we be talking about all options if they're not available from a resource perspective, or all options if they're futile? And so the answer is a bit more black and white there. I would say absolutely not. For the ethical principles of, beneficence, non-maleficence, futility, and then looking at justice, for all those reasons, if we don't have the resources, why talk about something that we can't provide, or if it's not in the patient's best interest medically? I don't think it's an option worthy of discussion. So I think ACP too late often, but professionals, medical professions have to wear the expertise that they bring to that conversation. Sumi?
Yeah, I think thank you for the question. I think it's an excellent, well, more than one question, excellent couple of questions. And I agree, I think, with just about everything that Gary said. Maybe to add on just a teeny weeny bit more. When you were talking about ACP and it being used for the ceiling of care, I find that somewhat problematic. And the reason for that is ACP should not be a tick box exercise. Do you want CPR? Yes, no. Do you, this is not this sort of type of exercise. It's although we're trying to gain an understanding of the patient's preferences, really what we're trying to do is to understand their values, trying to understand what's important to them. And those are, that is the underpinning information and understanding that we need, which then will guide the later decisions about, if this happens, what we should do, or if this happens, what we should do. So to just jump over all of that, or perhaps not focus on that enough, I think is problematic. And we may land up with an ACP that isn't really an ACP at all. So I think we have to be very careful what we label as ACP and how that process is conducted, because otherwise it's just, we're giving ACP a bad name if people think it's something that it's not. So that's the first thing. In relation to whether we should give options to patients when they're not available. Well, if they're not available, then no. I can see some sort of exceptional cases, right? So for example, there's a very expensive new drug, hundreds of thousands of dollars. The patient won't be able to afford it because you've got all their data and that it's not going to be affordable to them at all. But there could be options for the patient that they could pursue in order to procure that drug. And the crowdfunding is one of those, or there are other options, charitable options, and so on. So on that, I'm a little bit more on the fence because I think that depends on a number of factors about whether you tell patients or not. And very often patients do a lot of their own research and have found out that these things exist anyway. So then they may come back to you and say, why didn't you tell me about this? Or it doesn't matter that it's this much money. Actually, I have a very rich uncle or whatever it is. So you could run into some sort of trouble there. But if you're looking at a situation where not so much that the resources are not available, but that you're not sure resources may be available to this particular patient at the time, right? Because you're triaging, you're going through a process of triaging. So it could be that these resources could be available to patients, but it might not be as well. And that really depends. It's an evolving situation depending on the patients that you have at the time and various priorities, which would include clinical priorities. So instead of me rambling on, what I'm going to do is, as it happens, we did do a bit of a working paper on this, which I've just put into the chat, which the title of which is Intensive Care Triage, Communication and Support for Patients, Their Families and Healthcare Workers. So it's only a few pages. So if you're interested, have a little read of that.
I think we can continue a little bit. Certainly there's some more stuff that I think is worth delving into. Yeah, go on.
So this is another spin on it, and we talked about that tension of staff. So in fact, the intern that was working in my unit had just moved from a smaller sister hospital, and which had significant COVID outbreaks in that hospital. And she was found to be COVID positive in our unit on the day that the patient was transferred from our COVID ward, having gone through the isolation period and was now free of COVID in terms of infection and infectiousness, and had come to our unit. So now we have a positive palliative care unit staff member who had worked the whole day, who I had done a ward round with, as many other staff had as well. And this patient was now transferred. So I guess the question I'm going to ask you is, what needs to occur? What is it that we need to do? And does this change anything? Does it change her clinical care or any other aspect of care? What are the ethical concerns in this situation?
Oh, I was hoping somebody would say something in the chat or make a question. I'm not sure if I should say anything, but presumably the intern having COVID is not going to impact the patient who already has COVID, but it might impact how the unit functions, depending on what quarantine or other isolation policies that the hospital may have.
Yep. So do we need to explain? Do we need to say anything? Yes, it impacts the other staff, it impacts the other patients who've not been COVID positive. And I agree with you, Sumi, from a medical setting, she's not going to get infected again with COVID. So we shouldn't bother telling her anything really, or, well, she's unconscious, she's in the terminal phase. Do we have any duty to inform anyone else? Anyone?
Maybe it would be easier to ask not easier, but in your institutions, what would have happened? Big secret? No. I remember at one point we had quite a lot of our healthcare professionals who were isolated in various facilities around the island. So they were, of course, that put a lot of burden on other healthcare professionals. But at the same time, there was obviously a good reason for doing that. But because, of course, if more patients and healthcare professionals got sick, then things were more likely to grind very slowly to a halt. So again, depending on what kind of strategy your government stroke hospital are pursuing, then there may be various policies in place to put people in isolation for a while until they're clear before returning. But in terms of telling other patients, Yeah, I don't know to what extent it's obvious that if you're a hospital, there are going to be some some healthcare professionals who are going to get COVID, or is it something you should actively tell people? I mean, if there's a risk that that healthcare professional may have infected someone else, then it goes back to, again, what the contact tracing kind of policies are, whether it's the hospital or the government, in terms of notification. As I'm sure you know, contact tracing was quite rigorous in Singapore. So especially in the earlier days. So they would have chased all of this down, but I'm not sure what the position is in Australia or other places.
So I guess open disclosure. So one of the real important aspects is that in Australia we have a concept of open disclosure about any risks, any accidents, any incidents, and this would be considered a high-risk incident. So in fact, open disclosure, we then spent, two of us staff specialists spent the next 3 hours going to every single room, explaining to patients who were not in the terminal phase, who were awake, calling every single person responsible, and so open disclosure occurred. But open disclosure still had to occur in this situation, not with the patient, because the patient was in a terminal phase, but with their family members. And I think that was a really difficult time. And also now there was staff in my unit who were petrified that they were going to get positive. Just to let you know, in fact, our PPE policy of just wearing surgical masks and goggles prevented anyone, but we were also vaccinated. So none of us, in fact, became COVID positive, and we obviously had to have ongoing COVID tests, which I don't want to talk about because we want to talk about this case. So on the 7th, the patient actually died that night, the same day of the intern being found to be positive. And she would have been positive for the 3 days preceding it, by the way, but she started on that Monday. So then the question became, does this patient need a perimortem COVID swab? Because what are the morgue and funeral arrangements? So at this point, I throw it back to the audience.
Gary, I'll bring you back before this because we had a question that's come up with one of the nurses. What are the patient's rights if they are infected from the healthcare professional?
Well, that's a very interesting thing, and that's why open disclosure is required, because we need to, in fact, be very honest with any mistakes or issues that have occurred. And in this situation, you know what was the most interesting thing was almost every single patient that I could talk to who weren't in the terminal phase in my unit, and all of the next of kin and families, they weren't angry. They were actually very considerate and concerned for the intern and concerned about the staff, and said, look, it's happening in the community. We know this happens. And we had to diligently explain what the precautions were anyway that we'd all taken. And we had to ask every single member of families who then had come into the unit to have 48-hourly testing for COVID. And then we had to shut our unit. So there you go, Edmund, the end-of-life care 2-visitor policy that I fought for, we suddenly shut the unit, didn't we? Because we couldn't expose. We didn't know was there exposure or not. We were lucky there wasn't. So then my unit became a COVID, call a COVID ward, call a COVID amber ward, so which meant that there could be a risk, but there wasn't a COVID patient. What is the patient's right? Oh no, we've done that. Back to you, Ednan.
Oh, you've just posed the question, isn't it? Patient has passed away.
Yes, let's take that up.
You were wanting to see whether there's any responses and questions from the audience.
So do you think funeral parlours, funeral undertakers, etc., would be concerned? Do we need to worry about post-mortem transmission? What happens in your units or countries? Or do we treat it just as normal?
I think this is an interesting area. I would like to see some sort of comments, some questions, because certainly I work in the community, and certainly with the community, our patients are horrified when their family members who pass away are asked to go to hospital and have post-mortem to see whether they get COVID. And then you have all the disinfectant of grounds for funerals, which I find quite amusing in a way. So I don't quite know what's happening within the hospital situation, but certainly in the community there is a great deal of fear of what would happen if there was COVID detected. Would anyone want to comment or pose any questions on the rights of funeral parlours and those handling the bodies?
Maybe I can highlight a case that happened in Singapore recently, where our current policy at the moment is that if you are home recovery is now the default, unless you fall into certain categories, right? And lots of comorbidities and whatever it is. But for most people, it's home recovery. It's also recommended for people over 80. And so there was a man who was terminally ill who had previously expressed a wish to die at home. Now, he then subsequently caught COVID-19. So the question now was he required to go to hospital? Because there was this recommendation from government, if you're over 80, you should be in hospital. So he was treated at home by a doctor, and there was a team, home hospice team, to help him. And they decided that, well, because it was his preference to die at home, and at this point everybody around him was vaccinated, and he was terminally ill, and he didn't want to go. He didn't want to go to hospital. That he would be kept at home. The only thing was, after he died, he did pass away around friends and family and all the rest of it. There was a difficulty in relation to handling of the body, because there's obviously a protocol for handling it from nursing homes and from hospitals, but from home, no. So I think Singapore's in the process of updating, recreating these policies to enable people who are terminally ill to die at home, and for a process for their bodies then to be handled in a way that's compliant with the various rules, but also respectful.
Well, maybe while people are thinking, Ednan, if I go to the next slide, because there were some other funeral type concerns and death certification. So during the bereavement phase, a palliative care social worker kept ringing the son and daughter for bereavement follow-up. And the son was very distressed over several issues and kept calling the palliative care unit registrar. And one of the issue was the documentation of COVID-19 on the death certificate. And if you'd remembered, we said she died from a large stroke with an antecedent COVID-19 pneumonia. And the son in particular really wanted the COVID-19 removed from the death certificate. The funeral directors were concerned that the patient had COVID-19 and what precautions they needed to take. And really by that stage, our hospital had very good governance over post-COVID-19 clearance, which meant a proper letter, authorised by the hospital, etc. And one of the issues which has come up earlier is, what does COVID-19 impact on stroke and stroke on COVID-19 treatment? Was the family wanted to make sure, did she receive the best of care for her stroke? And did she continue her oral anticoagulants during her time when she was in hospital? Because was it that we just didn't provide her with best care because she was COVID positive? So there was a lot of bereavement issues, and in fact, the impression was the son felt a lot of guilt as he was the person who transmitted COVID-19 to his mum. So I think there were many issues, funeral, death certificate, bereavement concerns that occurred. And I think what I'd like to do is stop sharing that and really open it up to any type of conversation. Can I just ask, have I stopped sharing?
Yes. We've technically gone out of the allotted time, but I'm happy to keep it going for a little bit longer in case there are some further questions, because there's certainly some other issues around here which could be quite interesting. There's a question there's and come up.
I think it's Richard Lim.
Richard, you want to ask your question?
Hi, Gauri.
Hello, Richard.
Mitra. Hi. No, actually, I just wanted to comment because you wanted a bit of feedback about the previous question and what would we do here. I think the current situation actually it's quite clear. If a patient like the patient that we've been discussing, so she's been if she were exposed to the intern or not, I mean the contact tracing would actually be done. If there was deemed no close contact, then this patient actually after 17 days being in a COVID ward would be considered actually what we call off tag, and thereby her funeral arrangements and things like that would be considered as for someone who is non-COVID, and they don't normally check it again. They wouldn't re-swab a patient. I think what was the other issues? What would we do? The rest of it was the disclosure. Certainly we would definitely again do that the exercise to actually check and see who's been exposed, whether there was close contact, and those with close contact, of course, would have to undergo certain procedures. The occupational safety and health side will actually look into it. The public health side actually will also look at the exposure to patients and the other staff, and then they'll have to kind of there is a procedure that we have where certain people will be put under a quarantine for a while. They get swabbed. How many times you get swabbed? And it's kind of something like that. Our ward actually also had to lock down for like 10 days, and all of us were actually quarantined because it was a massive outbreak in our unit this year, somewhere around March. I think 3 of our staff nurses were involved. I think up to 5 of our staff nurses were infected, and I think something like 9 patients, and that included relatives of patients as well, who were kind of. We had that policy as well, allowing people to kind of help us. If we have an essential carer, we allow essential carers in the unit, because a lot of patients are disabled, and the essential carers actually got infected as well. In fact, I don't even know whether the essential carer survived or not after that. There was a case where there was actually a medical legal complaint, kind of taking the hospital to task, because there was a case where a patient actually got infected within the hospital, came in, was swabbed before coming in, definitely 100% non-COVID, but during the course of the stay in the hospital had become COVID positive, ended up in a COVID ward, and actually passed on. And the family actually, I think, have taken some medical legal kind of action and complaint. We don't know what the outcome of that is. I think there's still things going on. wondering actually, maybe Sumitra, whether you have some idea on that. I think some of them say that there has been, we're wondering what the responsibility is, because nosocomial infections happen all the time. And when COVID is so rampant, right, how do you actually, how can you be absolutely sure that a nosocomial infection isn't going to happen? And this is what it is. It's a nosocomial infection. Maybe Sumitra, any thoughts on that?
Is that the $100 billion question? I think it depends primarily on. I mean, let's put it this way: if the hospital was behaving irresponsibly, which I assume it's not, in the sense that they don't have any appropriate protections in place, staff are walking around spreading COVID-19, then I can see how legitimately the family would be upset and may want to pursue legal action against the hospital. But assuming that the hospital, and I believe that's probably the case, took the standard precautions that were required given the infection, and if it was incredibly and of course it was all over the place, it would be very hard to prove that that they got the infection from a healthcare professional as opposed to a visitor or their own loved one or whatever it is. But basically, if you took reasonable care, then you should be fine.
You can type set. Yes, so with contact tracing now, you can actually go right down to the source. So in fact, what would be required in that case would be to go diligently to the absolute source, and you'd be able to see whether it's got the genetic imprint of the staff or the genetic imprint not of staff, and therefore find it through the community. So yeah, it's a very interesting aspect. Oh, my dog's come to visit.
All right, thank you very much. Yeah.
So go ahead, Richard.
I would just say that also with our outbreak, actually, similar to what you were saying, Gauri, that we did actually have to explain to the family what was going on. But I think most of the time, I think if not all the families, they did understand, because we were actually having a very difficult and desperate time, and they understood it. And I think that is one of the things that, I mean, Ednin, you did say that it is difficult. Patients do actually have fears of coming to the hospital, but I think that fear is real, Yeah, thanks.
Dr. Shankar.
Just a comment regarding the son's concern about having COVID written on the death certificate. Actually, many of it is because I personally would put the blame on, the media. You know why? I believe that, people do get COVID, not, even by going to a shop just to buy something, or coming across a person who they, inadvertently met or something. But what is reported in the media is you get COVID because from a cluster, you've attended a function. They portray you when you get COVID as someone who has done something wrong. That means you've either broken the law or you have not followed the guidelines. So there is a stigma that, if my brother or my father or my relative has passed from COVID-19 and it's written there, that means, they have broken the law and it is their fault. I mean, that's my personal opinion.
Yeah, and I think in this case, I think the slide would have shown that one of his concerns was that he was worried the next morning the mother's death and the fact she died from COVID, brought in from home, would be splashed in on the headlines. Now, that obviously is not the case, because it's not juicy enough. We were having cases of COVID, we were having deaths. But yes, this real fear of stigma in your own local community. So what were friends, families, and mainly friends and community members think about it, or their neighbours, etc., if they found out that he had COVID and the mother died of COVID, etc. So people think in very strange and odd ways, and sometimes are very fearful of those implications.
Gary, overall, do you think that COVID changed the ethical perspectives of how we look at palliative care patients?
It reinforced the fact that palliative care, there is a global need in every facet of patients with advanced disease and end of life. It really strengthened the fact that palliative care had a voice and had to stand up and be heard and push and fight for good decision making and ethical conduct, good end of life care within an ethical framework, but really humanitarian, compassionate access. So, in fact, the pandemic taught us of the importance. It validated our discipline much more. So, therefore, I was very saddened to hear from some of my colleagues, in particular in the Asia Pacific region, who said that, in fact, palliative care services were closed, that many palliative care wards were converted to COVID, that their community palliative care services were removed. Now, all of us I had some of my staff furloughed or removed into COVID wards. Yes, we had to stand up and be counted just as a cardiology team or a neurology team. So we were one of them. That was great. But we didn't shut down. And so, you know, I'm really interested in your audience to comment on the fact that where services were shut, reduced, closed, not allowed to be involved, I think that's where the ethical dilemma was.
I think that's a very interesting perspective. And certainly one of the things, certainly with my unit, my own team, Gary, we all decided we would work. We would continue to work. We felt it was important to do that. And especially where we saw that, you know, there were quite a lot of hesitancy with some other healthcare professionals to do work. And we felt, why are we any different? This is the profession that we are supposed to be trained and do. So why should we opt out of something like this? So I think that's something I feel is quite important, to be stand up and be counted. Richard has a comment. Richard?
Yeah, thanks, Gary. I completely agree with what you say, and I think that it really did. I mean, this whole pandemic has actually demonstrated how important it is to actually ensure that, you know, palliative care services are actually available. Because I always say that, you know, it actually serves as a safety net for the community. And so over here, actually, early on in the pandemic, actually, we did really try to push, make sure that, you know, these kind of services continued. And it was good that the Ministry of Health actually was quite supportive of it. I know that the hospices had difficulties sometimes in traveling because of the movement control orders, and so we actually try to ensure that, you know, they could still visit patients at home. I think the only difficulty was when they needed to visit patients who were in this kind of, they have this what do you call the EMCO, or the some sort of I can't remember what E stands for, but it's some special exceptional MCO kind of area, which is extra lockdown or something like that. But but the sad thing, I think, that we about the situation was true that the COVID problem actually seemed to kind of supersede, or you know, take precedent, you know, priority in terms of what people were interested in, and things like where patients were at one point where we had the resources, even though someone was actually dying of a malignancy or something like that, but if they had COVID, they would actually end up in an ICU and have lots of aggressive treatments, because I think that having someone die from COVID, the earlier phase, right, was almost seen as, was frowned upon. You know, it's like a maternal mortality, and you can't allow that. And so that was one of the problems that we faced early on. Of course, later on, when the services and the resources were overwhelmed, then we I mean there was a lot of triaging which needed to be done. Of course, then at that point, we were quite the people were quite open to actually receiving input from palliative care, see how we could do things better. But I do hear that it's still quite lacking, and that there are still places where the management of COVID-19 then is it's just very the scope is so narrow, just focusing on the acute medical issues of COVID-19 and not everything else. Yeah, that's unfortunate.
There are two questions. One is asking, has COVID affected bereavement care? That's one question, and the other one I wanted to ask you, Sumi, is that were there many clinical ethics consultations coming in that were related to COVID over this past year or so? So one is bereavement care and clinical ethics consults.
Bereavement care, easy to say that we all went into telehealth. So a lot of our community work was through telehealth. We didn't abandon our patients at home, but we limited community visits. And then in the same way, bereavement consultations very quickly took on telehealth. And I've spoken to my bereavement colleagues and they say it's very difficult. That lack of being able to be face-to-face and looking at the nuances of facial expression or sometimes touch or handing a tissue and all of those other bits is not there. So they struggle, the bereavement officers, and they're really glad now that we've gone back to more face-to-face. You, Sumi?
No.
Short answer. I think we're coming. We've done nearly 2 hours of this, so it's been really fascinating, and we've got the majority of the audience still here. So really, thank you so much for everyone to stay on for an extra 30 minutes of having these two delightful sort of people here, Sumi and Gary. I hope it won't be too long before they're back here doing our normal ethics workshop. But really, from all of us at Hospice Malaysia, thank you to everyone, everyone that attended, everyone that contributed richly to the conversations that we've had today, and certainly Sumi and Gary. We'll see you soon, hopefully. Thank you so much.